I'm really just going to kind of get to the to some methods. So I'm trying to get this in, by 11:30. So the but welcome, and I think everybody gets like some CME for this. So anyway, I'm sure that's a way to do that. I know you have to fill out the survey. Anyway, this is a case I may have presented at this um, forum before. I'm not sure, but this is kind of a typical case of what we were seeing a couple years ago frequently, at least in our Espanola emergency department and our Santa Fe emergency department and some in Albuquerque. This was very common. So this was January 2022, and a 29-year-old female that she had been smoking 6 to 10 of the blue fentanyl tablets, and then she was advised by her boyfriend that she's got to get back on Subutex. She'd been stable on buprenorphine previously, and when she had been treated for opioid use disorder, but then she was destabilized when she encountered fentanyl, and which happened, of course, to a lot of our patients, right? So anyway, she's trying not to use. She's trying to do what she's done before when she transitioned from heroin or oxycodone. And so she waited about 10 hours after her last dose of fentanyl. She felt like she was withdrawing enough. She took some of the buprenorphine at an 8 milligram dose, basically following the directions we would have given her 4 years ago. And then she started having terrible precipitated withdrawal. So then she smoked some more fentanyl. She's still withdrawing, but it's all complicated now. And her boyfriend brings her to the emergency department. There's no alcohol or benzodiazepine use. And she shows up in a lot of withdrawal. Her COWS is 25. So that means she's really miserable. She's agitated. She's restless. She's rocking on the bed. She's vomiting. And the question was, what should we do? And at this time, this is almost 3 years ago, and we really were struggling with this. And we still often tried to just overwhelm the fentanyl with high doses of buprenorphine. And we tried doing that. And of course, it just got uglier, right? So I talked to the emergency physician who gives me a call, and she had already taken 8 milligrams. Then, of course, she took some additional fentanyl. But so, it was difficult to get an IV established. They're trying to give her adjunctive medications. It looks like she's clearly bound for the ICU at this point, or potentially going to leave AMA, right? So they really didn't want her to leave AMA. And so we started multiple adjunctive medications, everything they can give her orally, clonidine, benzos, then, of course, some IV ketamine. And meanwhile, they're trying to give her lots of buprenorphine. They're trying. So she ultimately gets another 40 milligrams of sublingual bupe before she just can't cooperate anymore for sublingual doses. So just her withdrawal is so severe, she's flopping all over, and she's starting to vomit, and she just can't, get them down. Because you have to be able to, hold it under your tongue, right, for about 5 minutes. And that's the challenge when you're really sick, and particularly when you're becoming incoherent, in part because of her severe withdrawal, but also because of everything we're giving her to try to ameliorate her symptoms. So she seems to get briefly better, and then she really worsens again. And eventually she ends up intubated, and she winds up on a dexmedetomidine and propofol infusion. And this was happening a lot. This was like a weekly occurrence for us. By the way, after this, I gave her injectable buprenorphine, and the next day she was extubated, and she did well. And then, of course, all that sublingual buprenorphine, she had gotten kicked in, and she felt a whole lot better the next day, right? So, but it sure made a pretty rough night and a very difficult several hours in the emergency department, and, of course, an ICU stay and getting intubated and mechanically ventilated. So we really try to avoid having those things happen. We're doing much better these days, but in part because we've learned a lot, but also because our patients have learned a lot. They've learned what not to do, right? Many patients have seen this kind of thing. So when we talk to our patients who are using fentanyl, the key information we always want to get is what's their pattern? What's their opioid use pattern? How many of those blue tablets, or how many of the grams of powder? Now, New Mexico, patients don't often speak in terms of grams, right, anymore. They often just speak in the terms of money they paid for it, which is the way they used to pretty much describe heroin in the past, and they pretty much describe how much they're spending. Spending a 20, a 40, I spent 100, but so often it's now sold in units of 20s or 40s or something, and it's currently going for about $100 a gram of this concentrated fentanyl powder, which of course completely random potency concentration. It's still pretty potent stuff, whereas the blue tablets are all over the place, as far as potency. Some have nothing in them, some have a lot of fentanyl. So anyway, particularly I want to know what they've been doing over the last 2 days, right? And also, when was their last use? So any recent methadone use and frequency, volume. Were they taking it regularly? Were they in treatment? Were they, obtaining diverted methadone regularly? Were they only getting a sip of it? And when was their last dose of methadone, right? And I have nothing against methadone, work in a methadone clinic, but we know, this can really complicate the initiation of buprenorphine, right? So, and if they took buprenorphine on their own, when did they take it? How long ago was it? How much? And, what happened? Did they tolerate it okay? Or did it precipitate withdrawal? So did they only take a little dose and they did okay with it and they're just afraid to take more? These are the history that it's just more complicated than the history we used to get, right? The history I used to get was really simple. When did you last use? when did you last use heroin? Just making sure you didn't use any methadone recently. Are you using alcohol? Are you using benzodiazepine? Yes, no, and then we just measure how much withdrawal they're in and we give them buprenorphine. I mean, that was sort of the simple algorithm we had, right? So we really want to know about alcohol and benzo withdrawal because it could exaggerate their withdrawal symptoms. We might think they're withdrawing a lot from opioids, from their fentanyl, but it really could be a combination of alcohol or benzo withdrawal, and we could be overestimating the COW score. And of course, I have found it helpful to know is the patient obese, they have a really high BMI. Since fentanyl is so lipophilic and builds up in adipose tissue, it's always easier to initiate buprenorphine on skinny people now than it is on people who are heavier. Right? So being thin is an advantage. And of course, female patients, are they pregnant, right? Because that really affects how we're going to initiate buprenorphine. And of course, we actually have to measure the scale. We actually have to see, what they're doing. And sometimes we just get cavalier about this. It looks like they're withdrawing enough. But these days we have to be a little more precise. And it's interesting, 5 years ago, I would just basically say, whenever the patient feels they're ready, just give it to them. They know. And it's just not that way anymore with fentanyl. Our patients need a lot of coaching and they need more guidance. Which is not to say we don't have a few patients who have now done this a few times from fentanyl and have kind of learned the ropes, right? Have that too. There's a lot of approaches to initiating buprenorphine. In the emergency department, we still occasionally do this macrodose initiation, where we just give them a big dose of buprenorphine, start them on high dose or even traditional doses, right? But we don't do it very often. Occasionally, we have the opportunity to do that. The low dose initiation, or what we were calling a Presbyterian rapid microdosing, it really wasn't standardized terminology until about 2 years ago. Honestly, all over the country, people are using different terms to describe this process. But low dose initiation is where we're going to keep giving them slightly higher doses of buprenorphine, but we intend to actually kind of do this while they're there in the emergency department. So. And of course, initiating with injectable depot subcutaneous buprenorphine. We're mostly using this brand, this Brixadi 7-day formulation for cost-saving reasons and for comfort. And then this process called Quick Start, which we've just rolled out in our Presbyterian emergency department, where we're actually going to intentionally give the patient naloxone. We're going to precipitate withdrawal and rescue them out of that withdrawal with buprenorphine. So we just started. This is what's happening in the world of EMS, although the EMS folks aren't giving them the naloxone to precipitate withdrawal intentionally. Patient's already in an overdose situation. So, and of course, we temporize patients with morphine, but we do this when we know the patient's going to get admitted. We temporize with morphine, and that gives time for the fentanyl to metabolize away. Morphine we like because it has very predictable pharmacokinetics, and people don't really crave morphine. Right? So, and then this gives us time to take a different approach later. Outpatient macrodose, right? This is where you just withdraw a whole lot. It's difficult. People don't succeed with that as often now as they used to. The low dose initiation, this is where the patient plans this whole thing out, and they do this over 1 to 2, maybe 3 days at home. And of course, that true microdosing, right? This is where they're going to do this over several days or several weeks even, sometimes people. And then, of course, we coach people through doing a quick start initiation at home, where they're going to do this naloxone facilitated precipitated withdrawal, and then be rescuing themselves with buprenorphine. So our inpatient is basically a lot of the same stuff, except I have to tell you, the easiest place to initiate buprenorphine in the world is the inpatient unit of the hospital, right? So, I mean, we do this every single day, like at Espanola Hospital. We have a really great order set. It's so routine. It's easy. This is, an opportunity for our patients that we shouldn't let slip, right? And maybe in the hospital a couple of days already, they've been getting morphine, and we can give them all kind of adjuncts. And we can do this nice and slowly. And we have time in the inpatient unit. We can do it over like 36 hours, which is what we usually do. Sometimes more slowly. We'll talk about that. And of course, sometimes we have a patient who's going to be in the hospital for quite a while. Sometimes they're transitioning from methadone, sometimes morbid obesity, other conditions, or they're just terrified of buprenorphine, and we'll go more slowly. Variety of reasons why. I do this a lot. I also do a lot of injectable buprenorphine, facilitated initiation on the inpatient unit. You can combine this with a low dose or a macrodose or even a slow microdosing initiation. And then when the time's right, you give them the injection. And I, by the way, have been helping our intensivists at Press, just educating them on this. And I use this actually a lot on people who are profoundly sedated in the ICU on dexmedetomidine and infusions. I get this to people who are intubated, and allows us to get them out of their withdrawal much faster and get them extubated or get them off of Precedex drip, get them out of the ICU. So a lot of advantages. And of course, we do the macro dose because it's easier to do in the inpatient unit, right? We know what they've been getting, and as long as we've searched them, we make sure somebody's not bringing them fentanyl or they're not using their own fentanyl, because that's usually the only time this kind of goes bad. But then as long as they're okay with going several hours without morphine and waiting for themselves to withdraw, then we can do the traditional approach. So sorry, I have a bit of a cold, but that's another thing we do. So but we temporize with morphine as our method of, regardless of what method we're going to then do, that's our preferred medication. There are times when hydromorphone is better, but I don't have access to hydromorphone. So macrodose, right? Outpatient or in the emergency department, right? This is, the patient just waits. They wait if they can do it, right? Until they're in at least moderate, severe withdrawal. Then they start administering at least 4 milligrams of buprenorphine. Sometimes starting with 16 or even 24 or so at a time. But usually you got to use, a lot of buprenorphine these days. Sometimes you have to give the patient a whole lot. I've given patients as much as 96 milligrams over just a couple hours in the emergency department. So of course it's easier to do in the emergency department, right? Because, it's a stable environment. It's actually a critical care environment, so we're certainly equipped to handle any complications. But even then, I've sometimes given patients 96 and then they're still not feeling well, and still takes them hours before they really make that transition. So it's just, it isn't the good old days. I hate that it sounds so weird to say the good old days of heroin, right? But that's sometimes the way we feel, at least from the ability to initiate buprenorphine. But in the old days, before fentanyl, when people were transitioning from heroin or oxycodone, rarely did I ever give anybody more than 32 milligrams like at a time in the emergency department. And now it's not uncommon for me to give just huge doses of buprenorphine, as long as they're responding to it, as long as it seems to be helping them and not making it worse. I'll just keep giving them more. So we still, like I said, occasionally get to treat people this way, but it's usually people who wound up in the emergency department out of desperation. In other words, they weren't trying to stop. They just couldn't get access to drugs. They, had their wallet stolen. They're off the street. They couldn't get medication anywhere. Or, at the behest of their family, they were trying to go cold turkey. We had a guy just show up last week in the emergency department. He had gone about 48 hours just trying to quit cold turkey. And unfortunately, he just arrived in so much severe withdrawal that he was delirious. And really took staff weren't quite sure what to do with him. He was in such withdrawal, couldn't get a good story from him, and he wound up in the ICU. But at that point, he was a lot easier to convert to buprenorphine. Successful groups, in the outpatient, basically it's people who can do this, people who say, I can endure, 24, 36 hours of withdrawal. It's miserable, but I've got enough, good social support, or you're going to give me enough adjunctive medication. I can handle it. But the truth is, in my experience, most people just can't do it. It's just so hard, right? And just a keynote, we should never plan a macrodose initiation in pregnancy, never. So just too high a risk for essentially precipitating labor, right? So that's what pregnant women do when they withdraw. They withdraw hard, especially later in pregnancy. Even earlier in pregnancy can miscarry. But we don't want to cause that kind of fetal distress. We don't want to risk abruption. We don't want to risk, preterm labor. So we never plan for a macrodose initiation. I have had occasionally pregnant women show up in the emergency department in terrible withdrawal, and sometimes they're appropriate for that. But typically, if we're going to do this, hopefully, if this happens to a pregnant woman, we hope they're in the first trimester. So, but once again, macrodose initiation, patient has to be actively withdrawing, right? And these days, I pretty much routinely recommend at least 24 hours. And I recommend 24 hours if they're thin, right? If they're lower volume users. If they're heavier, if they're higher volume users, I really recommend at least 36 to 48. I've still had a lot of patients with bad experiences, precipitated withdrawal at 24 hours, particularly if they're higher volume users, if they're heavier. But, this is, once again, you start like 4, 8, 16 milligrams. The higher the cows, the better. And typically I want a cows of at least 13 anymore when I'm doing this. And remember, we used to do this from heroin and or oxycodone or morphine. I just did this in the hospital 3 days ago for a guy. We just shut off his morphine. It was easy. We let his cows get to 8. We gave him a macrodose. He did fine. But that's the difference between transitioning from morphine and fentanyl, right? A lot of adjunctive medications are helpful. Anticipatory guidance, got to give a lot of it. And for your higher volume users, if you're really going to have them wait till they're withdrawing this long, then I usually start with big doses. And often we'll keep dosing them regularly. So I also want to make sure that the patient is observed. If we're doing this in the hospital, in the emergency department, we really want to make sure that we're observing and coaching the patient through each dose, because the patients panic and they get afraid and then they cheek their meds or they spit them out or they swallow them because they're not paying attention. So we really want to make sure that if we're doing this, we're doing it right. It's a terrible thing when you wonder why it's not working, and then you realize, well, it's because we didn't administer the medication properly. So we certainly see that. And if we're doing this macrodose initiation, I'm usually, assuming the patient is a good candidate for macrodose, I'm usually repeating 16 milligrams at a time. And like I said, I've sometimes given patients 96 milligrams or more in the emergency department. So, the home low dose thing, I do this often. I coach a lot of patients through doing this at home, that low dose, right? But the idea here is they're going to stop their fentanyl, and then they start taking the 2 milligram films. The biggest challenge is actually making sure the patient assembles everything they need, right? So they have to schedule the time. They got to make sure this is not when they have other obligation. They're supposed to be like babysitting, their sister's kids, right? Or something. You really want to make sure that this is all they have to focus on. Hopefully they've got some good family support. But when we're doing this, they stop the fentanyl. That's the key. They stop taking fentanyl, and then they're going to start, shortly afterwards, within the first couple hours, and start taking these tiny doses of buprenorphine. So 0.25 milligrams, that's essentially cutting one of those 2 milligrams into 8s, right? So your 2 milligram film, you're cutting into 8. And then they'll do that a couple doses. Then they'll double up, and they'll go to 0.5, so a quarter film. And the idea is they're going to do this every 1 to 4 hours, kind of as fast as they can tolerate. And as the day goes on, they actually are able to start picking up the pace a little bit. But I usually have them go through each dose twice to make sure they're tolerating it before they bump up to the next higher dose. And we're just progressively doubling the dose throughout this period. So when by the time they get to like the 2 milligrams, this is really kind of when they're going to make it. Like by the time they're tolerating 2 milligram doses, it's the same thing in the hospital. Once they're tolerating the 2 milligram doses, like they're over the hump, right? I mean, this is the hardest part. And now, we know that they're going to make it. And sometimes this is all that we get through in the emergency department. They can't be there very much longer. And if we can at least get them tolerating 2 milligrams, we can hopefully send them home with enough medication to get through the rest. Ideally, I like to get them, like in the ER, tolerating at least 4 milligrams before they leave. But at home, once they're tolerating the 4 milligram dose, that's when they start gaining a lot of confidence. They know they're going to get there. But hopefully by the second day, they get to 8 milligrams, but sometimes it takes to the third day, right? Sometimes they'll just keep staying at that same dose and dosing every couple hours because they're afraid, to go to the higher dose, and I understand that. So I give them lots of adjunctive medicines: clonidine, hydroxyzine, ondansetron, methocarbamol, NSAIDs, dicyclamine. I mean, I load them up. Trazodone, I give them trazodone to sleep. The one thing I don't prescribe for people doing this at home is benzos. While we may give them some benzos in the hospital occasionally to help them through this, or in the emergency department, and if we do so, we do it in relatively low dose, but I never prescribe them benzos to help them do this at home. And remember, you got to make sure you prescribe plenty of buprenorphine, because by the time they make the transition, they're going to need at least 24 milligrams. And sometimes on day 3, by the time they're tolerating 8 milligrams at a time, they're just going to take a whole lot of bupe. They're going to take like 6 or 8 tablets, that day, because they're going to have this deficit, and that's okay. So as long as they're not combining it with benzos or alcohol, they're probably going to be all right. So, and they're just going to keep taking it based on how they're feeling. I mean, that's what they're going to do. I mean, you can prescribe them, 3 tablets a day, but they're going to keep taking it until they're feeling good is what's going to actually happen, right? So you just need to be realistic when you're talking to them, right? So make sure that your patients have a good level of readiness, confidence, insight, good family support. This can be hard in patients with a high BMI. And this is low dose, right? This is what we're talking about, doing this over like 1 to 3 days. I find this is sometimes more difficult. I also have patients have a lot of anxiety. Sometimes they just won't do well trying to do this for 1 to 3 days. So a lot of other behavioral health, comorbidities, this can be more challenging. And of course, I never recommend in pregnancy. So although sometimes you're going to have a pregnant patient who insists that they're going to do this at home. They're not going to go to a detox center. They're not going to come in the hospital. They want to be on buprenorphine. And so you're going to have to give them very careful instructions and tell them that please, if they're not feeling well, please come to the hospital. Because the truth is, we want these days to transition every pregnant woman to buprenorphine in the hospital. That's where we prefer to do this, right? So anyway, like I said, takes about 1.5, 2 days or so, or sometimes more. We do this in the hospital, and our standard order set, it actually takes 30 to 36 hours because we do this order set, I think, every day of the week now. At Espanola Hospital feels like. And I prefer when they're getting their full mu agonists. And by the way, this is the difference. In the hospital, because we're not giving them fentanyl, because I'm giving them morphine, I give them all the morphine they want, right? Because morphine is so easily displaced by buprenorphine. So as long as we're gradually increasing their fentanyl, or excuse me, their buprenorphine, and we're dosing them, when we start typically at 0.5 milligrams or 300 milligrams buccal, 300 micrograms buccal, or even lower. Sometimes the patient has a lot of anxiety, or their fentanyl, last dose of fentanyl wasn't very long ago, or on OB. We typically start at 150 micrograms, buccal, which is equivalent to about 0.25, milligrams sublingual. But in the hospital, we just keep giving them their morphine. We give them all those adjunctive medications. We schedule their gabapentin, we schedule clonidine, and we give them hydroxyzine and other stuff, right? Methocarbamol, et cetera. But we just let them have their morphine. And they just take all the morphine they want. And we get through this, and it goes well. Okay? So that's the difference between doing this like in the hospital, which is why I'm saying it's so easy to do this in the hospital. You do this low dose initiation over about a day and a half. It goes well. So the problem with doing this in the emergency department is it really ends up consuming a lot of the staff time. Even if you're able to do it all through oral medicines, it's frequent reassessments, it's a whole lot of adjunctive medication. And when we do this in the emergency department, at least for Presbyterian, we do this in an accelerated fashion because none of our emergency departments have observation units. Now, if you've got an observation unit protocol, if your ED has one, and a lot of bigger emergency departments have observation units for treating asthma, chest pain, all kinds of conditions, which the patient's going to basically be in your ED for 24 hours because they may not meet like observation criteria in the hospital. But in your OBS unit, this is a good place to do this. So a lot of places that talk about their great success with doing low-dose initiation in the ED, and you want to ask them, the first thing is, do you have an OBS unit? Because that's really the difference maker. So when we do this in press, we're very selective about the patients we'll initiate because it's a lot of work. I don't think I'm pretty sure UNM doesn't do this at all. And the reason they don't do it is because they just don't have the bed spare, basically saying, okay, we're going to tie up a bed for 12 to 16 hours, initiating buprenorphine. And this is doing it fast, right? And we're only going this fast because we're snowing the patient with as much adjunct as we can give the patient, right? And often we're just trying to get the patient to tolerating 2 to 4 milligrams before they go home with a take-home pack to keep taking more. So it is challenging. That's my goal, at least to get them to 4. But sometimes the patients, they're there for 12 hours. They're finally tolerating 2 milligrams well, and they want to go. But you have to give them take-home bupe. They have to go home with bupe in their hands to continue the process, unless a family member was able to fill a prescription and they've already got the prescription in hand for them to continue taking, right? So, but particularly these days, prescription's insufficient, particularly where I practice in Rio Arriba County, because our pharmacies are out of buprenorphine like all the time, and people got to wait 2 hours in line at the pharmacy that has it. And so the patient's not going to leave your ED, still withdrawing, only tolerating 2 milligrams, and then go and stand in line at the pharmacy. Not happening. So got to make sure that if you're going to do that, send a prescription for the buprenorphine the minute you start this process. Get a family member down to the pharmacy, get them picking it up, so then they can proceed. So This is our typical kind of just schedule, by the way, in our hospital. You know, we give them all these adjunct stuff, right? Then we let them have all the morphine they need, right? And where sometimes our patients have really high tolerance. Sometimes they're getting 40 milligrams oral every 4 hours, and sometimes they're getting 10 milligrams every hour IV. And this is, you know, what you get if you're smoking 50 to 100 of those blue tablets a day, or you're smoking 2 grams of that fentanyl powder a day. Sometimes they need 60 milligrams every 4 hours. And this may be in addition, you know, to some Precedex as well. But we schedule the buprenorphine. The key thing we have to tell the nursing staff is don't measure the cows. You can get a cows, and the only purpose for getting the cows is to know if they're withdrawing poorly, but we don't wait for them to have a high cows for the dose. The goal is actually to keep the cows low, right? We'd actually like them to have a cows that's really low so they're comfortable, and we just keep giving them their buprenorphine, you know? So we just schedule them every 3 hours, and sometimes we'll go faster. We'll go faster if we're holding the morphine. If we stop the opioids, we'll go like every 2 hours. Sometimes we'll go every 4, every 6, depending on circumstances, you know, like I've talked about recent methadone, you know, obesity, other factors that we'll go more slowly. But every 3 hours is our standard, and that works really well most of the time. And we start with these low doses. Our usual starting is the 0.5. Sometimes we'll start, especially in OB, we'll start with like, you know, 0.25, which is like 150 buccal, or 0.1 milligrams IV. But we start a lot of patients with buccal or, you know, like the IV dose. I use IV buprenorphine, particularly for really sick patients in the ICU. And we get them to the point where they're tolerating 1 milligram sublingual, which is like 0.3 IV. And then we get up to 2, 4, 8, and we're just dosing them like typically every 3 hours. And then they get up to 8 milligrams. And then we often give them an injection of the injectable buprenorphine. I give injectable subcutaneous depot buprenorphine. I offer it to just about every single patient in the hospital. And the reason I offer it is because I want to make sure they leave our hospital loaded with buprenorphine, so in case they have any difficulty filling that prescription. The other reason is, you know, if you're smoking 2 grams of fentanyl powder a day, then 24 milligrams a day of buprenorphine isn't going to cut it. It is not going to control your cravings and withdrawal symptoms. You need to be on more, and the only way to give them more is to give them injectable and write a script for additional buprenorphine. So, you know, that slow rationale, that slow microdosing, this is where they do it over the course of the week, right? This is where, you know, they just keep using their fentanyl and very gradually increasing the dose. And I've had some patients who drag this out for like 5-6 weeks. You know, they're gradually working up to like full daily doses of like 16 milligrams, but they're afraid to go higher. So they keep going up at like 2 milligrams a day or less. You know, they're just so afraid of that bad experience. But most people, particularly if they're lower volume users and such, you can get them through this process in about 7 to 14 days. But dragging it out longer, not uncommon. But, you know, this takes a lot of motivation, and they have to be consistent with it. And anything that throws them off the schedule, you know, can just derail everything. So got to make sure they have got all the medication they need. And this is handy, like I said, for your really high volume users, patients with obesity, you know, been using methadone intermittently, anything that's going to make it harder. Sometimes people just opt for it because of their anxiety, worrying about that precipitated withdrawal because they've had that negative experience. Remember that everything we've, by the way, talked about, you know, microdosing and all this, that's not FDA approved. It's how we've adapted to it, right? But it's not the way it's been approved for use. So this is like a typical prescribing schedule, but I make sure they've got twice as much buprenorphine. Using the film is kind of handy. I don't prescribe the film very often unless I'm going to prescribe it where I want people to cut it up into pieces. But otherwise, plain buprenorphine is fine. I use that most of the time unless they request the film. The injectable, I'm almost out of time, so let me just real quick. This is the advantage of using injectable buprenorphine in your emergency department, is that it gradually releases buprenorphine. So you give them the injection, it starts working over the next 10 hours or so till it reaches about 80% of the effect, and then it reaches a full effect in about 24 hours. This is like low dose initiation on autopilot, right? So the patient just keeps getting more buprenorphine. So you just got to make sure that they're withdrawing, at least in mild withdrawal, that it's been a few hours since they've used when they start, right? And then if you give it to them right off the bat and they're not withdrawing, then it's too fast and they're going to be sick through it, and it's going to take a while to make the transition. So I usually often will give them a test dose of like 1 or 2 milligrams to make sure that they can tolerate that low dose, and then give them the injection. And then we'll give them additional adjunctive medications. Here's the main advantage. The patient's going to make the transition. you've given them, it's going to last for a week. It's going to keep releasing it. If you do it a little too early, you know, and the patient doesn't have enough adjunctive medication or adjunct buprenorphine, then that first 24 hours can be pretty crappy. But they're going to make the transition. That's the biggest benefit. And they're going to have it in their body, and they're not going to run out before they get to a pharmacy. It allows you to do this in the ED, so you can really accelerate that low dose initiation. You give it to them, they're tolerating it, you give them a bunch of adjunctive medication to take home, and then they can continue the process at home. They don't have to type to emergency department for 12 or 16 hours or so. And it frees up the staff time. And like I said, it's going to last, right? So you don't worry as much about them not getting to a pharmacy fast enough or not being able to fill their prescription, which is the bane of my existence every single day in Rio Arriba County, right? So if I find that particularly if you wait till they're into mild to moderate withdrawal, then this goes pretty darn smoothly, and the patients are really thankful, and you give them a bunch of adjunctive medications, and they get home and they do really well. So I'm basically out of time, so I'm going to skip the process, and I'm just going to talk about this one other note, which is this. And this is quick start, and I've talked about it once a long time ago, but we're actually doing this now. I've done this with several patients at home, and we're starting to make this a formal process. We have an order set for this in our ED, and patients don't need to be in withdrawal, right? So they could have used fentanyl like an hour before they walked in or an hour before you saw them or so. And now, granted, the longer they wait, the smoother this is going to go, right? But sometimes that's what we do. So we pre-dose them. So we give them a bunch of adjunctive medications. In our order set for the ED, and this is what I do for patients at home, right? But our ED order set, we actually have an IV equivalent. We'll start an IV. We'll make sure we got access to IV drugs. We'll give them some IV medications to get the process going. We'll also actually give them low-dose benzodiazepine in the emergency department, right? So then what we do is we give them the buprenorphine. And we call this the antidote before the poison. So we're going to give the antidote now. And the reason we give them the buprenorphine first is so in case they start vomiting with the naloxone, that they're going to be able to keep the buprenorphine down. Then we give them 4 milligrams of intranasal naloxone. You also can give them 2 milligrams IV. That's the other option. So that's our IV order set. The patient feels really crappy, 30 to 45 minutes, right? So within about 5 minutes of getting the naloxone, they're going to go into withdrawal. They're going to feel really crappy. Usually at an hour, they start feeling better. And about 2 hours, most people start feeling a lot better. Some patients are going to still feel, kind of cruddy and just gradually improving over several hours. So some people are going to be there longer. And the goal isn't to have them feeling perfect, but just making sure they've turned the corner, that they're improving clearly before you get them home. But you can see how you can turn around somebody in your emergency department in like 3 hours, right? Instead of like 16. And you can also give them an injection too. You can go ahead and give them an injection of the Brixadi, the sustained release as well. If you want to make sure that they're not going to have trouble getting to a pharmacy. The same thing, send that family member to the pharmacy immediately when you start, if possible, right? You got to make sure they have a buddy. You have to have a buddy when you do this at home. That's our guidance all the time. You do this at home, got to have a buddy, got to have a family member. Can't go solo, because if you do, you're going to panic, and then they're going to reach for the fentanyl, right? So got to have somebody committed to their recovery, committed to coaching them through it, being their cheerleader. And so, like I said, never alone. That's it. Sorry I ran over time. Just a reminder, everybody, prescribe. Nobody needs an X waiver. If you're doing this in the emergency department in your hospital, please make sure you give them at least a 7-day prescription to start. My routine prescription when I start seeing patients is 30 days. I don't want to make anybody run out before they can get back into clinic. Take home packs, give them. And then, of course, the number for the Poison Center, call us if you have questions. And I know I'm way out of time, so I'll just stop right there.